and in this session I'm going to talk about medical emergencies. Medical emergencies have a way of happening at any time, at any place. Are you prepared of it? Can you handle any medical emergency in your dental office? What if a patient after the treatment just falls down? Do you know how to treat it? It is best to be prepared for a medical emergency rather than wait for it to happen. So in this session, I'm going to talk about different type of medical emergencies that can occur in your dental practice and how do we take care of it. To begin with the most common medical emergency, that is vasodepressor syncope. Syncope is nothing but sudden transient loss of consciousness, usually secondary to cerebral ischemia. Now, predisposing factor of this syncope is either psychological or non-psychological. Psychological is basically because of stress, anxiety, pain, sight of syringe, sight of blood, sight of instruments, dental instrument, sight of dentist per se. Non-psychogenic factors are like standing for a long time in an upright position, or you could say the patient is tired, exhausted, hungry. These are the factors that could predispose to syncope. Now, the pathophysiology associated with syncope is that during syncope, the cerebral perfusion is decreased. As the blood supply to the brain is decreased, the oxygen carrying capacity is decreased, because of which loss of consciousness take place. Now, the clinical features of syncope can be divided into three groups: pre-syncope, syncope, and post-syncope. In pre-syncope, the patient will have perspiration, nausea, vomiting, doesn't like anything, will feel dizzy, and there will be slight form of an aura. Then come the syncope phase, wherein the BP starts to fall down. Initially in the pre-syncope, there is tachycardia, palpitation, the BP rises. And as the syncope approaches, the blood pressure decreases, there is bradycardia, the pupils are dilated, there is mental confusion, and the patient will collapse. In the post-syncope phase, the patient is still dizzy, doesn't know where he is very apprehensive, trying to adjust, trying to balance himself. These are the clinical features that can take place in syncope. Now, how do we manage syncope? Okay, now first is stop all your treatment that you're doing, see to the patient. If the patient is sitting on your dental chair and has an episode of syncope, you will recline the patient. That is termed as Trendelenburg position, wherein you put the head low below the leg level, so that you increase the blood supply to the head so that the syncope can be reversed. You keep that position for some time till the patient gains consciousness. If the patient gains consciousness, you can ask the patient to fold the leg to the knee so that the whatever blood has pooled down in the leg can move towards the brain. Or if the patient still doesn't regain consciousness, you could use spirit of aromatic ammonia. Now, this is a chemical agent which could stimulate your chemoreceptor mechanism in the brain and which could reverse the condition. If the patient falls down on the floor and it is unconscious, you have to see to that the airway is patent. Okay, when the patient falls down, the tongue falls back and blocks the airway. So how will you maintain the airway? By doing two things: head tilt, chin lift technique or jaw thrust technique. Okay, while doing this technique, you are moving the mandible ahead. Along with the mandible, the tongue move with it, due to which the airway is increased. If there is any object or something inside the mouth, try to remove it to prevent it to getting swallowed. Then the other you can say cause of syncope is orthostatic hypotension. It is a disorder of an autonomic nervous system in which syncope can occur when the patient assumes an upright position. Now, its predisposing factors are patient who are on antihypertensive treatment or medications, patient who have a venous defect, that deep vein thrombosis, they have varicose vein where there is pooling of the blood that occur. Okay, the patient wherein the venous drainage is affected. In that case, they are more at risk of developing orthostatic hypertension. So the basic physiology is that because of the pooling of the blood in the lower part of the body, there is cerebral ischemia occur, because of which syncope occurs. Now, how do you treat it? If it is an acute state of orthostatic hypertension, here it is mild, there will be no signs and symptoms of vasodepressor syncope. There will be slight decrease in the blood pressure and slightly high heart rate. Here the patient will not collapse, but the patient will feel a little bit dizzy. Okay. Now, in case of chronic orthostatic cases, there will be a loss of consciousness suddenly without any signs and symptoms of syncope. Now, how do you manage orthostatic hypertension? Place the patient, first of all, stop any kind of work that you're doing. Place the patient in a supine position with feet slightly elevated. Now, rather than that, you can ask the patient to sit in a more comfortable position. Okay, maintain the airway. Whenever you're doing a positional changes, when you're moving your dental chair from reclined to straight, make it slowly. And after the treatment, just do not ask the patient to stand up and go. Once the treatment is over, you recline the chair, tell the patient to sit for some time so that he can adjust to it. Okay, once the patient is able, tell the patient to stand for some time. If the patient is able to balance himself, then tell him to walk a distance and sit on a chair. Always see to that the patient is accompanied with someone or the other. Normally, in case of a normal person, when you're doing a postural change, there is decrease in blood pressure followed by a drastic increase in blood pressure within 30 seconds. But in case of orthostatic hypotension, this mechanism is hampered. So this transition doesn't happen, because of which patient collapses. So you need to make any postural change that you're making in your dental chair in a gradual manner. Then we come to hypoventilation syndrome. Hypoventilation is nothing but ventilation in excess of that required to maintain the normal blood partial pressure of carbon dioxide and oxygen. Now, causes of hyperventilation could be of anxiety, could be of fear, it could be because of toxicity of drug, it could be because there is some nerve damage has happened because of that, because of toxicity, some central nervous system defect it could occur, because of cirrhosis can occur. Now, the basic pathophysiology behind hyperventilation is the patient is trying to breathe. There is increase in rate. There could be either increase in depth of respiration or it could be both. So because of hyperventilation, the amount of carbon dioxide increase and it get accumulated in the chest and thoracic system, because of which chest tightening is experienced. So patient feels that enough air is not going inside the lung despite he's breathing too much. So patients try to breathe more, the rate he tries to increase the rate more, because of which the carbon dioxide keeps on accumulating. And this results in hypoventilation syndrome. Now, what are the manifestations of this? Cardiovascular manifestation is there will be palpitation, there is tachycardia, there is increase in blood pressure initially followed by depression. Neurovascular system, it is dizziness, it is confusion, there is titinous muscle twitching. Respiratory, there is dyspnea, there is loss of breath. Muscle, there will be cramping of the muscles will take place, especially respiratory muscle. They can, cramps can occur in the respiratory muscle titiness and fatigue can occur. How do you manage this condition? Terminate all the procedure. Position the patient in a more comfortable position. In this case, you will not do a Trendelenburg position because there is no cerebral ischemia in this case. Okay. Here the patient is trying to breathe, but still he thinks the air is not entering in the lungs. So we'll try to make the patient more comfortable to the situation. Now you correct respiratory alkalosis. Here in hyperventilation syndrome, respiratory alkalosis take place because of accumulation of carbon dioxide. So how will you treat it? You'll ask the patient to breathe carbon dioxide in rich air because this will stimulate your central nervous system. And it will say that, yeah, there is carbon dioxide, I need to expire it so that I can get oxygen. Okay, so how do you do that? You ask the patient to breathe through a paper bag. If not, breathe through a face mask or place his hand around the mouth and breathe. If that is also not sufficient, if the patient is unconscious, you can give diazepam IV 10 to 15 milligram or you could give intramuscularly 10 milligram. If not diazepam, you can offer a midazolam IV 5 to 7 milligram or IM 5 milligram. This is basically will decrease the anxiety of the patient and eventually treat the condition. Now asthma. Asthma is nothing but hyperreactivity of your tracheobronchial tree to any kind of you can say antigen. Either it could be in form of an insect or pollen grain or dust or fumes. Okay, wide variety of aggregating factors. Okay, so hyperresponsiveness of your tracheobronchial tree, wherein bronchospasm occur, bronchial edema occur. Okay, and mucus secretion is increased. Now all these four things result in airway flow limitation, airway hyperresponsiveness to a wide range of stimuli. There is inflammation of bronchi with eosinophil T lymphocytes and mast cells and with associated edema. and there is smooth muscles, hypertrophy, and mucus plug formation is seen in asthma. These are the 4 classical features that you could see in asthma. Now the pathophysiology is basically you can say airway lining is thickened. Now this lining is thickened either by muscle formation, either by edema, because of which the line become thick, because of eosinophilic infiltration, inflammation, and secondly because of thick mucus formation. So your normal airway become constricted. So you require more energy to breathe, because of which the asthmatic attack occur. Now these slides show a variety of the asthmatic triggering factor, the agent that could cause asthma. Now the clinical manifestations are, in mild episode there is thickening in the chest and coughing, there is wheeze, dyspnea, there is rise in blood pressure and rise in heart rate. In severe case, instead of dyspnea, there is cyanosis. There is precipitation, flushing of the face, use of accessory muscles for respiration, fatigue and mental confusion. Now, status asthmaticus is a worst type of asthma attack, wherein it is a state at which the acute asthmatic episode persists in spite of drug therapy. That is, you are treating an asthmatic attack but it keeps on continuing. It's termed as status asthmaticus. Now, signs of status asthmaticus is fatigue, dehydration, severe hypoxia, cyanosis, peripheral vascular shock. Now, how do you manage it? Okay, first of all, try to calm down the patient, give 100% oxygen. Start with IV hydrocortisone 200 mg followed by prednisolone 40 mg per day orally. Start with nebulization with beta-2 adrenoreceptor agonist, that is salbutamol 2.5 mg 24 hours 4-hourly. Now all these agents will cause bronchodilation, will decrease the spasm and increase the patency of the airway. Now if improvement occur, reduce salbutamol to 8-hourly. Check the vital signs of the patient, check the vital capacity of the patient and then eventually discharge the patient. Now if improvement doesn't occur with all this treatment, then you have to start nebulization with the ipratropium sodium 500 microgram or IV aminophylline 250 milligram. Monitor the oxygen saturation. If after doing this treatment also the patient's state is not improving, then you have to shift the patient to artificial ventilation. Now, acute adrenal insufficiency. We're all aware that adrenal cortex secrete a number of hormones, okay? The most important of it is cortisol. Now, decrease in cortisol production can result in acute adrenal insufficiency. Now, predisposing factors for this could be because of, it could be overweight, it could be pregnancy, it could be hyperthyroidism, hypertension, can cause the acute adrenal insufficiency. Alright. Now, clinical feature is that there will be mental confusion, muscle weakness, intense pain in the abdomen, hypoglycemia, extreme fatigue, nausea, vomiting, hypertension. There will be syncopal episode, coma, hyperpigmentation, loss of weight, craving for salt and water. Now, how do you manage adrenal crisis? Now, treatment should be stopped. If you're doing any kind of dental procedure, stop it. Position the patient in a more comfortable position, administer carbon dioxide rather than carbon dioxide, give 100% oxygen, give 100 mg of hydrocortisone IV over 30 seconds. IV infusion of 5% dextrose plus 100 mg of hydrocortisone over a period of 2 hours. If still the condition doesn't improve, for severe hypertension occur, then you need to administer 0.3 to 0.5 mg of epinephrine intramuscularly or intravenously. Now basically these things occur in patients who are on long-term steroids. So when you're posting for a patient for dental treatment who are on long-term steroid, you need to consult the physician whether you have to stop the steroid or not stop the steroid, because dental procedure itself is a stressful procedure. If already the glucocorticoid production is less, it will cause decreased adrenocorticotropic hormone release. We need these adrenocorticotropic hormone to manage the stress that occur in dental treatment. So if that is less, so eventually it will aggravate and cause adrenal crisis. So in that case, you need not stop the steroid. You need to increase the amount of steroid and then eventually taper it. But the best thing would be to consult the physician and then do it accordingly. Then we come to the diabetes mellitus. Okay, now the Predisposing factors of diabetes mellitus. It could be genetic, it could be injury to islets of Langerhans cells, or it could be any kind of, you can say, surgery done in the pancreas that can affect the tumors of the pancreas. Now, there are two main types of diabetes mellitus. Okay, insulin dependent diabetes mellitus and non-insulin dependent diabetes mellitus. Now, basically concern the clinical entity that affect during our dental practice is hyperglycemia and hypoglycemia. Now, you will ask me which one is better, which we can treat properly. Both of them are not good. Okay, your glucose level should be in control when you're treating a diabetic patient in your dental chair. Why your glucose level need to be controlled? Now, increase in glucose level provided an enriched medium for the bacteria to grow. So if you're doing any kind of surgical procedure, there are high chances of infection in these patients. That's the reason why you need to maintain the glucose level. You need to maintain at a specific level. Now, so you would say less glucose level is also good? No, of course not. Less glucose level, there are chances of syncopal attack can occur. In that case, you need to maintain the glucose level. Suddenly the patient will collapse. You don't know the collapse is because of what? Because of syncope or because of hypoglycemia or hyperglycemia. All of the three things can cause. So none of these is important. The important thing is you need to have maintain the glucose level. Now, what exactly happened? Now, in case of lack of insulin, there is decreased anabolism and there is increased catabolism. Now, what I mean by anabolism? Whatever glucose is produced, the body is not able to utilize it, which eventually result in hyperglycemia. Now, more amount of glucose will cause fatigue. There will be glucoseuria. Osmotic diuresis take place. Okay, that means salt and water will automatically deplete. There is polyuria, polydyspia, because of which there is tachycardia and hypotension, and eventually death can occur. If increased catabolism, that what I mean by increased catabolism is that if there is lack of insulin, there is glycogenolysis. That means glycogen is broken down into glucose, so glucose increases. There is no new gluconeogenesis, means glucose is formed from fats, lipids, proteins, more glucose is formed. This causes lipolysis, there is loss of weight, which eventually result in hyperketonemia, which causes acidosis. Now, these causes peripheral vasodilation and hypoventilation. There is diabetic ketoacidosis, which eventually result in death. This is the cycle that takes place if there is lack of insulin. Now, we begin with hyperglycemia. Okay, it is nothing but a classical triad of polyphagia, polydyspia, and polyuria. Okay, now it is untreated. It can result in diabetic ketoacidosis, result in diabetic coma. Now the signs are there is florid appearance, okay, hot dry skin, hyperventilation, rapid pulse and decrease in blood pressure. Now how do you manage hyperglycemia? Okay, now in clinic if the patient become unconscious when you're doing any procedure and if it is because of hyperglycemia, which should not happen because you should have taken a history and checked the glucose level, but still if you have missed to do that and if the patient become unconscious, you will give an IV line and administer 0.9% of saline with 1 liter in 1 liter in 30 minutes plus potassium chloride 20 milliosmol because you want to maintain the osmolarity. This is followed by IV insulin 6 units stat. Then you will give 6 units 6 hourly or intramuscularly 20 units of insulin stat or 6 hourly 6 units 6 hourly. Okay, if the BP is below 80 mmHg, then you have to transfuse whole blood. If the pH is below 7, then you have to give sodium bicarbonate 1.2% in 500 ml of saline plus 100 milliosmol of potassium chloride. This is basically you're trying to maintain the osmolarity to prevent ketoacidosis to occur. Let's move on to hypoglycemia. Now, clinically manifested hypoglycemia, you have two phases, early stage and late stage. In early stage of hypoglycemia, the patient will feel hungry, there will be nauseous, fatigue, confusion. And in late stage, the patient, there will be decrease in heart rate, there will be hypotension, and eventually the patient will collapse. Now, how do you manage hypoglycemia? Okay. Now, recognition of hypoglycemia, first you see that the condition is because of hypoglycemia. Check the vitals, administer oral glucose, that is 20 to 40 gram if the patient is conscious. If the patient is unconscious and non-responsive, then you have to give IV 50 ml of 50% dextrose in 2 to 3 minutes. The patient should recover. If the patient still doesn't recover, then you can give intramuscularly glucagon 1 milligram. Now this glucagon and dextrose both available, unavailable 0.5 milligram dose, then what you could do is give 1:10,000 of epinephrine. This will take care of it. Let's move on to epilepsy. Now epilepsy is nothing but recurrent convulsion produced by paroxysmal excessive neuronal discharge in different part of the brain. Okay. Now if the epileptic attack occur continuously without any recovery, then it is termed as status epilepticus, which is a life-threatening situation. Now the clinical features of epilepsy is divided into two broad categories: prodromal phase and convulsive phase. Prodromal phase, the patient will feel dizzy and the patient will have an aura that something is going to happen. Now in convulsion phase, the actual seizures will start. Initially there is tonic movement in the extremities, they will become rigid. Okay, after that there will be clonic movement. Clonic movement will start to move, there is excessive, there is dyspnea, there is struggling for breath, there is frothing from the mouth can take place and the patient will collapse. Now how do you manage an epileptic patient? Now position the patient in supine position. Prevent injury to the patient by putting any kind of soft object below the head or between the teeth. Any kind of object that were present in the patient's mouth when we were treating, try to remove all kind of object, all sharp instruments. Okay. If possible, do not put your finger between the teeth because there are high chances the patient can bite your finger. You could put a soft object to try to avoid it. Immediately give an IV diazepam 10 mg stat. Start the IV infusion of 200 mg of diazepam over a period of 24 hours. Okay. Now once the patient is stabilized, see the patient, you shift to an oral anti-epileptic drug by a form of tablet phenytoin 10 mg twice a day. Now you can also use phenobarbital 50 mg as an alternative to diazepam. Let's move on to the thyroid functions. Thyroid dysfunction. There are two major varieties. Okay. Hypothyroidism and hyperthyroidism. Hypo is because of decrease in secretion of thyroid hormone and hyperthyroidism is because of increase in secretion of thyroid hormone. When I say thyroid hormone, I am talking about T3, T4 and TSH. Okay. Now acute condition of hypothyroidism is termed as myxedema coma. Its diagnosis is made by cool, pale, dry skin, cold intolerance, confusion and unresponsiveness. Now, how do you manage a myxedema coma? Stop the procedure, maintain the airway, give oxygen, then apply blankets because the patient cannot tolerate cold temperature and administer T4 hormone, that is thyroxine hormone. Okay, if the patient with hypothyroidism is undergoing any kind of surgery, elective surgery, then you have to give thyroxine 75 mg to 150 mg per day so that the patient become euthyroid. Check the vital signs during the surgery. Emergency surgery, in mild to moderate cases you can do it. But in severe case of hypothyroidism, avoid the surgery, consult a physician. You will always try to make the patient euthyroid before any kind of treatment. Otherwise they will go into myxedema coma. Now if it occurs, then you could give hydrocortisone. A dose of 100 mg is given to prevent adrenal insufficiency. Oxygen diuretics should be started to advise with the help of the physician if it is required. Those drugs that are CNS depressant, like if you use halothane general anesthesia, or you could use propofol, they depresses the central nervous system. They have an exaggerated response in hypothyroid patient. Means even a small amount of dose which is normal, which you give in normal patient, will become a toxic dose to hypothyroid patient. So drugs which are CNS depression should be used very cautiously. Okay, let's move on to hyperthyroidism. Now basically hyperthyroidism, the patient will either have a goiter or a swelling in the neck. There will be tachycardia, palpitation, tremors in the hand, exophthalmosis will be present. The patient are intolerant to heat. Whereas in contrary to hypothyroidism, in hypo the patient cannot tolerate cold. But in hyperthyroidism, the patient is not able to tolerate heat. Now, if this hyperthyroid state is not treated, there is hypermetabolic crisis occur, is precipitated in these untreated patients and can result in thyroid crisis, which is an emergency stressful situation. Now, how do you manage hypothyroid crisis? Okay, first of all, before you go to manage, you need to diagnose that yes, this is thyroid crisis. Here the temperature will increase. It will be more than 105 degree Fahrenheit. The pulse is more 140 per minute. The hypotension is there. There is 90 mm of HGBP will be there. There will be severe fatigue and convulsion. This will show that there is hypothyroid crisis. Now, how do you manage it? Stop the procedure, rehydrate the patient, give propanol 80 mg 6 hourly orally or 1 to 5 mg IV. IV hydrocortisone 100 mg slowly to decrease T4 and TSH level. Okay, carbamazepine can be given 10 to 20 mg 8 hourly to control the seizures, and sodium iodate 500 mg per day to restore the T3 level in 48 to 72 hours. Now, if the patient with hyperthyroidism is undergoing surgery, elective surgery, okay, postpone the surgery and manage the patient with anti-thyroid medication, that is carbimazole, that is 10 to 20 mg 8 hourly for 1 to 2 months, so that the patient become euthyroid. Okay, now urgent surgery, you could give hydrocortisone 100 mg 8 hourly, decrease the level of T4 and TSH. Now, thyroid crisis, that is you can give profile thiouracil 400 mg loading dose after 1 day of then eventually you could gradually decrease the doses. But on the first day you have to give 100 mg of loading dose. Let's move on to anaphylaxis, the most dreaded of all the medical emergency. What if the patient come to your dental clinic and need an extraction and you have injected local anesthesia like normally you do to all patients, and suddenly you see all the rashes developing on the patient's hand and eventually the face, and there is swelling of the lip. You don't know what to do. Yes, this is actually an allergic reaction. So anaphylaxis is a classical type 1 immediate hypersensitivity reaction. It is body immune response. It is exactly an exaggerated immune response to a particular antigen after being sensitized for the second time. Okay. Now, in this case, how will you diagnose it? Here you will do a skin test and a patch test. Okay, skin test is you will inject 0.5 to 0.3 ml of the solution subcutaneously, okay, and check for wheal and flare. You will basically check for the diameter of wheal and flare. Okay, if the diameter is more than 4 into 4 for adult and 3 into 3 for children, then it is termed to be as positive. Or you could do a patch test. You will take a patch of that specific drug, 2.5 into 2.5 centimeter patch, put on the skin of the patient for 2 days and then cut off that tissue and send for biopsy. On biopsy, if you see infiltration of inflammatory cells like eosinophils, basophils, lymphocyte, then it is termed to be positive. Clinically, these patients, you will see rashes all around the body. There will be edema of the lip. There will be difficulty in breathing because of the bronchospasm that has occurred. Okay, now how do you treat anaphylaxis? The first line therapy of anaphylaxis is give 100% oxygen, maintain the airway. Now start with epinephrine subcutaneously 0.1 milligram, 0.1 ml per kg to maximum 0.2 to 0.5 ml you can give, and that too in a ratio of 1:1000 dilution. Now start with fluid 5% dextrose in 0.5% normal saline solution, or you can offer a ringer lactate solution. Now second line of therapy is use of antihistamine. Now you could use diphenhydramine hydrochloride orally, or intramuscularly, or intravenously you could give 1 milligram per kg to maximum up to 50 milligram every 6 hours. Along with antihistamine, you could offer corticosteroids like hydrocortisone 100 milligram IV, or use of a bronchodilator is very good like salbutamol, or aminophylline you can give IM intramuscularly 5 to 6 milligram per kg over 20 minutes. Now these are the line of treatment that you have to do in case of anaphylactic shock. Last but not the least, the drug overdose reaction. Every drug has a potential to produce adverse reaction if it is given in higher than usual therapeutic dose. The most important drug that we use in maxillofacial surgery is the local anesthetic. Now, local anesthetic can produce overdose reaction. Now, predisposing factor can be broadly divided into two things: patient factor and drug-related factor. In patient factor, we have to check the age of the patient. Then we have to check the weight of the patient. We have to check all the route of administration, whether we are going intramuscularly, whether we are going infiltration or we are going block, or whether it is going directly into the arteries. So we need to see that. These are patient factors. Drug factors is route of administration, what kind of formulation we are using. All these factors will determine your overdose reaction. Okay, now etiology is that it can occur when you are giving anesthetizing, more amount of solution is being used. A solution is being directly deposited into the central system. Okay, arterial system can cause overdose reaction. Because of elimination, biotransformation and elimination of the drug is less in case of liver and kidney disease where it undergo biotransformation. If that is hampered, then even small amount of drug can become toxic and can result in etiology. Now, etiology of overdose, initially everything is enhanced and then it is depressed. So there will be palpitation, tachycardia, heart rate is increased, blood pressure is increased, and eventually everything will become decreased. Okay, that is, there will be hypotension, bradycardia, hyperapnea, dyspnea, and eventually loss of consciousness. How do you manage an overdose? Okay, position the patient in a supine position, maintain the airway. Okay, try to manage the seizures. Administer carbon dioxide, ensure the patient airway is patent, monitor vital. Give an anticonvulsant. After 4 to 5 minutes, diazepam 2 mg per minute IV. Then you give methoxamine 20 mg IM intramuscularly for lowering the blood pressure. Okay, then permit the patient to recover after discharge. Okay, see to that the patient has revived completely. The most important thing is whenever you're doing a dental procedure, make an attempt that the patient is always accompanied. You never know when an emergency can occur. It's better if the patient has someone to accompany them. What if the patient moves out of the clinic and then fall? So you should always see to that the patient is always accompanied. With this, I would like to conclude by saying that when you prepare for an emergency, the emergency ceases to exist. Thank you.